everybody, and welcome to this next episode of Blood Matters, a podcast for nurses. As always, I'm your host, Emma Chalmers, and joined by my co-host, Michelle. Hi, Michelle. How are you today?
Hi, Emma. I'm all good today. Thank you very much. I'm really looking forward to today's pod.
Yeah, we never have a pod that we don't look forward to, but that's because we make the pod, so we can help create what we want to learn about as well. This topic this week, though, has been brought to us by our audience. The guys at the annual meeting suggested doing a session on this, and this week we are doing nutrition, which is a little bit different, but actually really exciting.
Yeah, exactly. And I think there've been quite a lot of developments recently in, the guidance and advice that we should be giving to our patients before, during, and after stem cell transplants. So that feels like a really good place to start the discussion today. And I think we're going to have a really good old chat on the pod. We've got a couple of really great guests coming up, which should be quite interesting. Maybe sharing views completely, or maybe having slightly different experiences, because we have a guest from the UK and a guest from Belgium. So really looking forward to seeing what the conversation brings today.
Yeah, as always, we have our clinical experts that we have gone out and sourced to join us for the podcast, who will be joining us shortly. And just a little plug again, guys, as usual, if you want any particular topics to be covered by us, give us a shout, let us know, and we will put something together. We'll find some experts and we will do that podcast for you. So as always, it is down to you if you want to do something particular. Although we do have quite a cool program coming up over the next few months as well, don't we, Michelle? Really excited about what we've still got planned.
Exactly, yeah, and all will be revealed. Do make sure that you signed up to the newsletter, the EBMT newsletter, e-learning newsletter as well, and that's where you'll get to find out what's up and coming on the Blood Matters podcast for nurses.
And you can also subscribe with us on both Spotify and YouTube, so you will always get your alerts to say that there's a new episode that's been released when we have sent it out. All right, well, I think without much more without further ado, let's introduce our guests when they've joined us. So now we're really happy to welcome both of our guests today. We've got Nicola and we've got Christel, and we are really excited to hear kind of the views and experiences of you guys. So welcome to the podcast. Thank you very much for joining us.
Welcome.
I will do a little introduction to Nicola, and then Michelle will just do a little introduction to Christel, and then we'll probably dive straight into the questions. So we've got Nicola Scott here, who has studied at Queen Margaret College in Edinburgh, which is actually where I studied as well. So, original group here. Having a BSc honours in dietetics. Initially, Nicola worked for NHS in Stevenage and then moved to Sheffield in Yorkshire, and then joined Leeds Teaching Hospital NHS Trust in 2002. Nicola is currently a senior specialist dietitian in haematology, having worked in this field for the last 16 years. And Nicola also has her master's in nutrition through the Leeds Beckett University and obtained that in 2016. Nicola does have a particular interest in working with patients who are undergoing stem cell transplants, which is great because that's our topic of choice, but also more recently CAR T cells. She's also a member of the Haematology Subgroup Committee of the Oncology Specialist Group of the British Dietetics Association, and has been for the past 16 years. So a very warm welcome to you, Nicola, and thank you so much for joining us today.
And I'm delighted to also welcome Christel Kuppers, who's also a clinical dietitian, and she started that career in Brussels, in Europe hospitals. And then since 2011, she's worked in Jessa Hospital, Hazlitt, on the haematology ward, where she's been able to integrate dietary advice into the daily haematological care of patients, both in the inpatient and in the outpatient settings. She's also really interested in clinical nutrition and dietetics, with a focus which is particularly relevant, I think, to a lot of our patients, on parenteral and enteral nutrition. And over the past 10 years, she's been president of the Commission of Oncology of the Flemish Dietetic Association. And at the moment, she's still a very active member of that group. So we have really two amazing clinical experts with us today. I think we should just dive straight in and start with our questions and let them take.
I agree. And I hope you guys agree too. But thank you again. Thank you so much for joining us today. We're planning to start with you today, Christel. Although we've done Nicola's introduction first, we'll start with Christel. What we're going to do is just ask you a question, let you chat to us, and then Michelle will ask you a question afterwards. So we'll do it in that kind of construct. So I guess really what we want to ask first of all is probably what's the biggest challenge for patients nutritionally after they've had a stem cell transplant?
Yeah. First of all, I want to thank you for the invitation. I think it's really nice that nurses also are really interested in the nutrition part of stem cell transplantation. And I like the way how you said my name, Christel. It's a French way of saying it, but I like it. It's okay.
How should we say it?
Yeah, in Dutch it's Christel, so it's a little different, but I like the French way as well, so it's okay. To come back to your question about the biggest challenge that I see post-transplantation, I think it's really difficult for patients to get their nutritional needs for recovering. The nutritional needs in fluid, energy intake, protein intake, they're very high. And because they still have complications of the treatment and medication, it's really difficult for them to meet the needs that they have. Because of the complications, a lot of patients still experience dysgeusia, mucositis, also anorexia. It's still very common after transplantation. So it's really difficult for them to eat well and to get to the point that they need to get to get enough energy, protein to recover well. That's at the beginning. After the transplant, but if we look a little bit more further, like a year or something, it's also difficult for them to eat healthy again, because at the beginning after transplantation we're so focused on energy-rich food, high in nutrients, high in protein, so they get a different way of eating habits. And then after a year, we need to say, now it's really important to get back to the healthy nutrition. So we can prevent a relapse, so you don't get cardiovascular disease, don't get diabetes and stuff. And I see that transition, again, is also a really big challenge for the patients. So I think it's two big challenges at the beginning and a little later.
That's really interesting, because we do focus on that sort of 100 days sort of fixed number in our heads quite often, don't we, in terms of what we are doing for the patients. But you're right, and longer term. Thank you for that really interesting point. Michelle's got the next question for you.
Yeah, I just thank you very much, Emma. I just wanted to ask you, Christel, just for people in our audience who may not have come across the term dysgeusia, if you could just briefly explain what that is, and then I'm going to ask my question.
Yeah, okay.
Valid.
Dysgeusia, it's the loss of taste, impairment of taste. So a lot of patients experience a different kind of taste. Everything tastes like metal, or they don't taste anything at all. That's the term of dysgeusia. Yeah.
Amazing. Thank you very much. And yeah, really interesting that you talk about this kind of rebound weight gain that we see in patients, particularly year 1 to year 2 after transplant. I'm lucky to see a lot of our long-term follow-up patients, but we do a lot of work with them around nutrition and rebound weight gain from transplant. And of course, you know, the fact that they have not only changed nutritional habits, but also a more sedentary lifestyle during that period of time. sort of almost compounds the issue for them. And it has a real impact on body image and confidence in terms of reintegration for them. So it's a massive problem that I think is very under-recognised by many health professionals. So it's great that you've brought that up. So my question really is around the difference that you might see between nutritional compromise in somebody who might have received an allogeneic transplant versus somebody who receives an autologous transplant.
I want to say that both types of transplants are, they're affecting the body, both. But I can see in the follow-up afterwards that autological transplant patients, that they recover a little bit more quickly. I think about 3 months, and then they recover, kind of say, where that the allogenic transplant patients, they have a longer period that they still suffer from the complications. A lot of them are due to the medication that they need to take afterwards with the cyclosporin and stuff. And yeah, I think that's the biggest difference, that they just recover more quickly, the autologic and versus the allogenic. But the complications that they get, like the taste problems or the anorexia, I think it's the same in both groups. So the biggest difference is the time, I think.
And do you think we see the rebound weight gain as often in the autologous patients as we do in the allogeneic patients, and we're just not seeing them in the same way or as frequently during that period of time? Or do you think that's less of an issue in the autologous patients because the timing, the duration of anorexia and GI impairment is shorter?
Yeah, I must say that my autologic patients, because of the recovering that it's more quickly, I don't see them as long as the allogenic. So yeah, it cannot really say it's true or not, because I don't see them that long. But when I do see them again, it's because of relapse, and mostly they are back on their weight at which they started the treatment the first time. So it might have to do something with the weight gain again. Yeah.
Thank you very much, Christel. I'm going to hand over back now to Emma.
Thank you very much. So when I was sort of putting the questions together, I was doing a little bit of looking into who our guests are. And one of the things that I noticed that you have done, Christel, is implemented something called tasting boxes in your hospital. Could you tell us a bit about these tasting boxes? What are they, and what's the benefit for the patients?
Yeah, the tasting box is a method that I use, especially for patients with taste problems. During the treatment, but also afterwards, when they are readmitted to the hospital because of the eating complications after stem cell transplantation. It's I must say, it's a very intensive and time-consuming method, but it's really satisfying when it works. And it's literally me going around at the ward with a box, a basket with different kind of nutrition in it, different kind of elements in it, like an orange or a cake, a cookie, some potato chips or something. And then I'll go to the patient's room and we will try different kind of foods, and using all senses to try the food. So we start with seeing, looking at it, the sight. If it's okay for the patient to have a look at it, doesn't he or she feel uncomfortable looking at the food? If it's okay, then we'll pass on to the touch. And then it's the patient really get to feel the kind of food. So with the orange, for example, they can really feel, and we talk about it, if it's okay or not, if the texture of the food feels comfortable for him or her. After the touch, we go on to the smell. If it smells okay, then we also discuss a little bit if it has a good smell or a bad smell. Why does it smell good or bad? And if it's okay, we pass on to the latest step, the taste. And at that point, the taste, it's in two. We start with tasting with the lips. So not directly into the mouth, but first tasting the texture with the lips. And then if that's okay, then we'll pass further to the mouth so they can really taste all the taste inside the food with the taste buds in the mouth. And if it's okay, they can swallow. If they say at that point, no, it's also not okay for me, then it's good to spit it out. It's no problem. But in this way, we create together a list for the patient with food that work well, with food that doesn't work. And the first few days we'll do it together. Afterwards, I'll give the patient some homework to do it themselves, that they need to try like 5 foods a day. And then we'll talk about it later on. But it's nice to see that they have, it motivates the patients to try some foods again, because if they have a lot of longer time that they cannot eat because of the dysgeusia, the anorexia, a lot of people get demotivated to try new things. Mm-hmm. And if you come with a big plate full of nutrition, they won't try. So it's this is an easy way to start small, to get them to the bigger steps, to eating a complete meal again. And it's really satisfying to see if it works. But like I said, it's time consuming, so I cannot do it every time. It's only for patients who have a really big problem with eating. Yeah.
I love this idea. I think that people forget sometimes that food and eating food isn't just about the taste, isn't just about putting something in your mouth. It involves all your senses. So that sounds like a great idea of way of kind of, like you say, reintroducing foods or trying to learn the new foods that maybe are tolerable versus what has previously been eaten. Fabulous. Well, thank you for this so far, Christel. Stay with us, because at the after we've spoken to Nicola, we're going to do our quickfire round of questions where it's sharp answers. I'm going to pass over to Michelle to ask Nicola's first question, but as I said, thank you very much for those answers so far, Christel. Been great.
Thanks again, Emma, and thank you, Christel. So, Nicola, now we're kind of moving, shifting focus slightly, and really thinking about sort of nutritional prehabilitation, I guess, really, and there's a lot of excitement about prehabilitation, not just from a nutritional perspective, but also a psychological and physical perspective as well, in terms of mobility and optimizing people's physical health before and movement before transplant. So my question really focuses on what we can do to advise patients, or what patients can do prior to transplant to become a bit more robust nutritionally.
Yeah, thanks, Michelle. And thank you again for inviting us to talk. Yeah, I think prehab, like you say, is really sort of setting the world. I think it's becoming one of the big areas of where we need to sort of focus our attention on, really. And yes, nutrition being a big part of that, like you say, along with sort of psychology and exercise. And I think for our patient groups, when they're coming up to stem cell transplant, they've probably maybe for a lot of patients been through many rounds of chemotherapy, so nutritionally can be depleted already. But I think it's a big push for kind of getting well-balanced diet, trying to go towards the food model of regular protein intake throughout the day, ensuring that we've got carbohydrate, the fruit and veg. So just trying to get a well-rounded diet approach, really. But I think the other thing that patients can do is be aware of what's happening with their own weight as well, and ideally trying to keep that steady, trying to preserve that muscle mass and function before coming in for stem cell transplant. And I guess that's where the activity can really help as well, along with diet, to get them in that best possible situation before coming in. And obviously, if we are losing weight, then trying to implement some of the, high energy, high protein. So again, maybe turning their diet a little bit from sort of the healthy approach, but again, really trying to push to make sure that they are as robust as we can.
And a lot of patients will ask about alcohol, Nicola, whether they can drink any alcohol during that time, post-treatment, pre-transplant. What's the dietetics take on that?
I mean, I guess from our perspective, we will always go towards the medical team and just ask them what they feel. I mean, from a dietetic perspective, we're probably ensuring that they're trying to limit their alcohol within, sort of the national guidelines. But I guess we would be focusing on what the medical team, along with pharmacy, from a medication perspective as well.
Yeah. Thank you very much, Nicola. I'm going to hand over to Emma now. Thank you.
Yes, I'm back again. So now I sort of want to bring it forward a little bit to just after the transplant. And obviously we do have quite a lot of nurses listening to this podcast. So maybe just asking a bit of advice about what could be done if patients are becoming at risk of malnourishment in the hospital in that sort of immediate post-transplant phase. What advice would you give?
Yeah, I mean, I think, starting point of just ensuring that, regular nutrition screening is part of the nurses, ensuring that, we've got sort of regular weights, food record charts, so that we can actually highlight these sort of patients very early on in that process. I guess from a ward perspective, we do a lot of adaptations with kind of menus. We're quite lucky where I work, in the sense that we've got several different menu options. So we will look at trying to, encourage sort of, maybe finger food, smaller portions, regular snacks throughout the day. And I guess, for a lot of patients, meal times are very strict within hospital, and it's having, as much as we can, that allowance for snacking or eating in between meals as well, where they're not eating, large portions. So really trying to emphasize that little and often approach, and ensuring what they are having at that point is high calorie, high protein. I know we go on about this, but really trying to get those, two nutrition elements in. We will very often look towards using and trialing sort of some of the oral nutritional supplements. So again, just to try and balance out patients' intake throughout the day. And again, with the taste changes, their anorexia, again, giving them a bigger variety to look through, trial. One doesn't suit every patient. So again, having that big variety to try. But we will quite often move towards enteral feeding, and particularly with, say, our myeloablative allogeneic transplant group, we're very proactive, and we will put prophylactic feeding tubes in, because we know that they're potentially a patient group that are going to struggle with their nutrition throughout the stay. So we are very proactive at trying to encourage, patients with the acceptance of nasogastric feeding tubes and the benefit, towards that recovery that they can give.
Amazing. So there's still lots that we can do very early on to sort of help with that. Absolutely. I'm kind of pass you over to Michelle for the next question.
Thanks, Emma, and again, thanks, Nicola. So this is I guess, a question I'd like to throw out to both of you, really, because there might be a slightly different take depending on which country you might be practicing in, or which country you might be listening to this in. So it's around the current guidelines advising on clean diet. It would be great if we could get to a point where there was a kind of Europe-wide standard, with some local variation within that. I'm not sure we're really there yet, but be great just to hear your views on this first, Nicola.
Yeah, I think this is probably one of the most controversial areas for dietetics. Do we actually need a clean diet, neutropenic diet? And I think we, within the UK, updated our guidelines very early on, actually, this year. And some new guidelines came out in, I think, May of this year. And we've really tried to take away a lot of the restrictions. Many of the restrictions are historically there from years ago. And I think there's been, a massive move in how transplant patients have been treated, antibiotics, everything, but nothing's ever dared to move on with diet. It's always stayed very much, the neutropenic diet is there. Within the UK, there's quite a number of institutions, units that have actually gone very much well away from having any sort of neutropenic clean diet, and they haven't really seen any consequences in increased infections. So we took all this on board, and we had conversations, and we have tried within the new guidelines to really sort of limit and just been focused around food safety, food hygiene. There was a couple of big research papers that came out in America, which really focused around food safety as opposed to restrictions. So we've added back in things like salads, fruits, vegetables, as long as they were washed. We're not saying things have to be peeled and they have to be avoided. So I think now we've gone very much just along the line of food safety. So, no unpasteurized foods, making sure meats are well cooked, they're not raw, same with fish. But I still do, and I agree, Michelle, I think it would be really nice to have a European approach so that everywhere was doing exactly the same.
Well, maybe yourself and Christel can have a chat about maybe coming together and developing a group to maybe move towards that. At least outlining some basic principles that could be utilised across Europe. And Christel, your views and your experiences on clean diets.
Yeah, I think there's a difference in the Flemish and the Wallonian part in Belgium. Our guidelines are also about safe food handling. So it looks a lot like in the UK, I think. But I know in the Wallonian part of Belgium, they're more strict, and they still cannot eat every kind of fruit or vegetable. When it's raw, it's not allowed. Strawberries, for example, are not allowed in the Wallonian part. So I'm also really cheering for a European guideline. I think it's difficult if you go to one hospital or another, and that the treatment is the same, with all the medication and the chemotherapy, the antibiotics, but there's still a big difference in the way we treat it with nutrition. And I think also there needs to be it would be good if there's a consensus European-wide. So
yeah, completely, or at least a kind of an agreed framework for nutrition. Covering all of those three key areas, well, four, I guess, if we think about the weight gain long term. So, the prehabilitation aspects, the, peri-transplant area, and the immediate discharge, and then the longer term, it would be great for some basic guidance around that, for sure. I'm going to hand back to Emma now for her final question to you, Nicola.
Yeah, I love that we come on the podcast and we end up creating ideas and potential work for people. We don't mean to, but certainly it sometimes happens. So I think the last question I've got for you, Nicola, before the the quickfire round, would be, what's the longer term advice we should be giving to patients? It links back to Christel's point about sort of that changes, but what are we giving, what should we tell the patients when they're away from us potentially?
Yeah, I think we've got, like you say, a very much an immediate recovery stage still. And like you say, around maybe that sort of first year when we know requirements and everything are still high, and they still may be needing to follow some of that advice that was given in hospital around the higher energy, high protein foods. But then, like you say, it's moving back towards really trying to emphasize that, healthy diet approach, and maybe working towards, we tend to look towards the World Cancer Research sort of guidelines, and promoting kind of, looking at weight, trying to promote the healthy BMIs, and looking at overall sort of, calorie intake, and ensuring kind of, processed meats, red meats are lower down, and, trying to avoid high sugar foods, drinks, ensuring a good sort of fruit and vegetable intake. So we tend to try and, as much as we can, then move towards that more sort of healthy eating. But like Christel said earlier, sometimes that's very difficult because patients get very stuck in the ways of how we've tried to approach it through stem cell transplant. And, we often talk again a lot about body image and how things are through that whole process, and trying to move them onto that healthy eating, because obviously we know for future and for cancer prevention in the future, that's the way we need to be heading towards. So, really sort of focusing on maybe those guidelines, and again, pulling the activity into that side of things for looking at long-term health benefits as well.
I guess it's about the rehabilitation aspect of post-transplant being not just a few weeks afterwards, it's the longer term, isn't it? Well, thank you for that, Nicola. That was great. So we're now going to move over to the quickfire round.
I'm going to ask my first quickfire question to Christel and then to Nicole. So, Nicola, sorry. What's the myth around nutrition you'd like to debunk? Sorry, we're changing everybody's names this morning. I apologize. What is the myth around nutrition you would like to debunk, Christel?
A myth that's still very alive here in Belgium is that eating soup is very good when you're ill. And every time I need to debunk the myth, because I always say to my patients, soup, it's only warm water with the taste of vegetables in it, but otherwise it won't bring any nutrients to you. So it's only a good idea to eat soup if you can make it a kind of a meal soup, add some energy to it, like breadcrumbs or pasta or stuff like that, and add some proteins to it, like meatballs or lentils or some cheese, and then it's okay for me to eat soup. Otherwise, when you're ill, it's not the best kind of food to eat. Yeah,
I love that. Nicola. Over to you, Nicola.
I think one of the things that we still get quite often is that sugar feeding cancer, and I think for us that's still one that we have to try and battle, and that having sugar doesn't make the cancer grow, by also depriving yourself of the sugar doesn't make the cancer grow any less and any slower. So that for us is one that we're still battling on with. Interesting.
I wouldn't have thought, obviously I'm not having nutrition conversations at the same level as you are with the patients. I haven't heard that for a while. So gosh, it's awful to know that is still alive, that myth. Over to you, Emma, for the next quickfire.
I'm laughing at myself here. I don't know if you're watching it on YouTube, you'll have seen my face as Nicola said that about sugar and how frustrating it is. And we don't have the time to sort of go right into all of the other myths around nutrition that are thrown around in terms of cancer and the amount of questions it asks, but it is a bit of a bugbear for a lot of people. So I'll stop. I'll calm down. So for my next question for the quickfire round is, what can nurses do to support patients who are struggling to eat? We'll go to Christel first.
I think it's important to help motivate patients, because we give the advice as a dietitian, but we're not there the whole time. So nurses are the ears and the eyes, kind of say. So I think it's important to help motivate them with frequent snacks in between, with ONS, the oral nutritional supplements and stuff. I think that's a really important thing to do, to help the patient, motivate and stimulate.
Yeah, you're right. The nurses are there all the time. So they are the perfect person, aren't they? Nicola, what about yourself? What do you think?
And mine was exactly the same. It was about trying to be really positive with the patient, being positive about what they're managing, even if it's small amounts. But like Christel said, we go on, we give the advice, and we're not always there, lots of time. And I think the nurses are in such a great position to have those conversations, and also have the conversations with families. What can they bring in? What can they tempt them with? What's appropriate to bring in? And things. And I just think, being really positive and giving that, trying to just re-emphasize any of the advice.
Yeah, totally. I think experience from my centre is that you can't rely on the patient asking for the snacks. You kind of almost have to keep going to them and pestering them and saying, hey, do you want a snack? Hey, I noticed you didn't eat much of your lunch. Do you want some toast now? Or do you want some, you've got to, just start being very annoying, I guess, to your patients. Probably think that you're quite annoying, but actually you've got your best interests at heart. Michelle's got the last quick fire round question before we start closing off the podcast. So back over to you, Michelle.
Thanks, Emma. I just wanted to add, actually, just around that whole kind of struggling to eat aspect, is that often, I think, particularly when our patients get out of hospital, they remain in a sort of being fed mode. So, they don't necessarily make their own food choices. The food choices are often made for them by a carer who becomes the feeder, and the patient becomes the person that's being fed. And one of the things that I try to do is encourage patients, I guess, in the same ways as you've both mentioned, to be a more active participant in those food choices. So, if there's a little shop round the corner and they're up to going there for 10 minutes, go and have a look at the shelves. If you're not feeling inspired by the food that you're being given, have a look around, kind of, and plan sort of in those early days, sort of think it, eat it foods. So, stuff that doesn't take a long time to prepare. So, the casserole and the roast dinner that you start preparing in the morning and you eat in the evening, you're not going to want it by then, because you'll have completely changed your mind. You'll have been smelling it all day. It'll be something that you may need to put in the freezer for another day. Little pots of stuff, although they're quite expensive, better than throwing food away that doesn't get eaten. And things that can be prepared very, very quickly, and things that have got lots of sauce with them, lots of gravy, not to the extent of soup, so flavored water stuff, where will be probably a little higher in salt than you would normally eat, to bring the flavor out of the food. And that whole stuff around food tasting different and textures of food being very different when it's cold versus warm versus hot, and how that really plays around on the taste buds. And finding that group of foods, maybe with the tasting boxes, that works on the palate for that moment, and expanding on that, but not bulk buying and investing in that. I had a patient who found that ginger beer really worked for him, or ginger ale, the non-alcoholic version, worked for him after his transplant. And his wife came home with 3 crates of ginger ale, and he didn't like it the next day. And it's like, this massive crates of reminding him of his inability to tolerate certain foods over long periods of time. So sort of more active participation in your own food choices is kind of something I think is really important, particularly as people get a little further out post-transplant. So sorry, sorry to witter on about that.
Always helpful, always good info from you, Michelle. Don't worry.
My last question for you both, I'm going to start with Christel, is where do you see dietetics in the future in terms of transplant and cellular therapy?
Yeah. First of all, I don't have any experience with that at the moment, because we don't do it in our center.
But with
I think
transplant and cell therapy, so I kind of group those things together.
Okay,
because,
okay.
I think we're not yet at the stage where we have dietitians only specialising in cellular therapy.
No.
And we often kind of use the terms in exchange, really. So transplant and cell therapy.
Okay, in general. I think it's really important that the malnutrition screening still continues also in the future. My dream is, but I think it's also a little bit center dependent, that we can make the follow-up even more than it is right now, because at this moment we only have a follow-up for a short term of period, only when the patients do have the complications after transplantation. But also, like we already discussed earlier, even later on, it's also very important to guide them back to a healthy lifestyle, not only nutrition wise, but also with physical therapy and stuff. So I think there's still much more room to guide the patients back to a normal kind of life. So I think we as a dietitian can also play a big role in that later on. Yeah,
normal and healthy life.
Yeah.
And Nicola.
I've probably got two things. One, I'm quite invested in prehab. So I think for me, I would love to see, all patients having some form of prehab before coming towards stem cell therapy, really. So I think for me, that would be a huge move in the future towards being able to get that. But I think as well in the UK, really just having dedicated dietitians for units, because I think we've done, several surveys, and I know a lot of units don't even have, dedicated time and specialist dietitians. So again, I think that is a huge part of investment in workforce that we need for dietitians to have, the input there with the MDTs. So those two things probably for me.
Brilliant. Lots of food for thought there. Food for thought.
Oh, I like what you did, Christel. I like that. I imagine so many eyes rolling across the country. People be like,
I'm really sorry.
Someone had to say it.
Different co-host with Emma next time.
I mean, my usual thing to say is teamwork makes the dream work, and we haven't had that this time around. But I like the food for thought. Oh dear. Well, on that note, we're going to close off the podcast now. I would like to say a huge thank you to both of our guests, Nicola Scott and Christel Kuppers, for joining us today and for giving us really, here's one for you, a taster into nutrition around and about stem cell transplants. And as always, we could talk about this for many, many hours, and unfortunately we don't have that time, but I would like to really thank you for your input today, because I found it super interesting. I've been scribbling lots of notes down, so really appreciate it. Thank you so much for joining us today.
Yeah, huge thanks again to you both. Really, really insightful. And actually, I think this is our first podcast where we've had other health professionals.
Yes.
We've had doctors and nurses, but we haven't had any allied health professionals on so far. So you're a first for us in the Blood Matters podcast series.
We're honoured. More please. If people have ideas, more please.
Yeah. So huge thanks again.
Well, how interesting was that, Michelle? I've got ideas as usual.
Yeah, no, it was brilliant, and that marks our first podcast with allied health professionals, which is very exciting. We've had doctors, we've had nurses, and that's our first allied health professional pod. So I'm very excited about that. And I think it's a very, I think what interests me most about working with allied health professionals, I'm very fortunate to do that in my role, is their different perspective. They look at life through a different lens. They look at our worldview through a different lens, and I love that, and I love that what that does for patients and for patient care. So yeah, it's always great to hear a different perspective. And it's great that we have both Nicola and Christel from different countries. So we have, UK and Belgium represented. So their different perspectives were great. And I think for me, the idea that you might divide up nutrition, if not, physically in a framework, but thinking about nutritional opportunities, because I think nutrition is an opportunity often missed for nurses into that sort of prehabilitation, pre-transplant time period, that peri-transplant time period where patients are in hospital and they're having all the immediate effects of the chemotherapy and the immediate days after cell infusion, and then in the immediate recovery post-discharge, and then that long-term follow-up setting where we can do a lot to promote health as nurses. But we have a lot of missed opportunities for nurses where we could have a greater influence on our patients' nutritional management in collaboration with dietitians and nutritionists in our hospitals.
Yeah, I think it's really easy for us as nurses to sometimes underappreciate what happens in the longer term for these patients, because we're not necessarily going to be seeing them, especially if you work in a transplant unit. You're not seeing them hopefully not seeing them 6, 9, 10, 12 months later, are you? But it's good I think it's really good to know what that difference can be. And I really like the point that we got from Christel about how to sort of almost approach that dysphagia, that taste change, that palate change, and the tasting boxes sounded fantastic. I really think that's something that I will certainly be promoting my centre just as a way, and it's certainly an empowering tool for nurses to do as well. I'm not saying that nurses need an additional role, but they've got that time, if you're sort of offering things to the patients, having that conversation. I think
it sort of plays into that whole kind of food aversion stuff that our patients get, really, isn't it? Which is, I don't think we fully appreciate is so multisensorial. So, the kind of the smell and the appearance of the food, often our patients will be put off immediately that a plate of food comes through the door because it doesn't look like a food that they want to eat.
There's 3 courses on one tray.
And that whole idea of offering that flavouring, sampling, but also utilising the senses to kind of feel your way around the different food varieties, I think is just such a great idea. As Christel said, it's quite time consuming. But I think, and clearly it's not an area for nurses to develop, because clearly it needs to be done with the supervision and the training that our dietitians have. But the way we think about foods for our patients as nurses could be influenced by that model.
Absolutely. I think it's all kind of almost the psychology of eating and things like that, which we're not necessarily going to be experts in, but we can certainly be part of the team, I guess, that approaches that.
For sure.
And I think that we've obviously put some ideas out there. Hopefully somebody might be thinking, I want to put together a European consensus on nutrition post-transplant. Maybe we've inspired some people out in the listening pool to start those conversations. That would be fantastic. So I think that there's lots of, as you said, food for thought. It's funny, it's a pun, but it's not inaccurate. There's a lot of things to think about around nutrition, and we're hopefully this podcast has started some of those conversations out in the world. So I think wrapping it up, I just thank you very much for being my wonderful co-host as always, Michelle.
Thank you, Emma.
And I would like to say to folk, if again, I said at the beginning, but if you've got any ideas for a podcast and you want us to do anything, please get in touch with us. You can get us on the usual social media sites, or you can get us through the EBMT website or via your newsletters. And there'll be a link in there that you can use to contact us. So please let us know what you would like to do. If you have any questions or feedback on this podcast, same route, same direction. And please do have a look at our previous podcasts if you've not listened to any of them, and you might find something else that's of interest that you can take away to your learning or your centres. And the other people to thank, as always, are the background team who do all the wonderful editing and putting it all together and promotion on social media. So thank you very much for the team behind us. And please join us again for the next podcast, as always, and have a lovely week, month, whatever it is that you've got coming up. Thanks, Michelle.
Thanks, Emma.